Hello, everyone, and welcome to the next episode of Heart Success Podcast. Today, we have an international guest with us, Dr. Carolyn Lam. We will be talking about a couple of topics. In the first half, we will discuss management of heart failure on the inpatient side of things. We spent a lot of time talking about medications for heart failure, but we're going to go a little bit into management of heart failure in the hospital. Let me make you aware of the risks associated with failure to continue, initiate, or switch guideline-directed medical therapy during hospitalization. There are studies which showed that if you fail to do this, there is an increased risk for readmission and short, intermediate, and long-term mortality. Also, there is lower medication adherence and lower medication persistence. The whole problem with medical inertia sets in, which is why you want to be able to make these decisions in the hospital. There is a substantially increased likelihood of never being initiated on appropriate guideline-directed medical therapy as outpatient if those decisions were not made in the hospital. Also, really, it's missing out on a teachable moment during these patients' hospitalization and making the patients aware of why these medications are important and the different drug classes that they need to be taking. After discussing the role for triple or even quadruple medical therapy among heart failure with reduced ejection fraction patients and initiating most of this therapy in the hospital, we spent some time talking about drugs that could potentially exacerbate heart failure hospitalizations and have a negative impact on the overall outcomes. In the second half of the episode, we will be briefly talking about heart failure and preserved ejection fraction, sort of an introduction into the topic. We will have future episodes where we will explore this topic further. Dr. Lam is a senior consultant of the National Heart Center in Singapore and professor of Duke NUS Cardiovascular Academic Clinical Program. She graduated from the Faculty of Medicine, National University of Singapore, completed her advanced specialty training in cardiology in Singapore, and pursued her research fellowship at the Cardio-Renal Laboratory. She also did a heart failure fellowship at the Division of Cardiovascular Diseases at the Mayo Clinic in Rochester, Minnesota, and advanced cardiology and Masters of Biomedical Sciences at the Mayo Clinic. She further obtained training in clinical and genetic epidemiology at the Framingham Heart Study in Boston, Massachusetts, before returning to Singapore in 2010 on the National Medical Research Council's Clinician Scientist Award. Dr. Lam's clinical subspecialty is heart failure, and she is recognized globally for her expertise in heart failure with preserved ejection fraction, and she is a clinical trialist. She serves as a consultant on several global advisory boards for cardiovascular disease, as a member of the executive committees of global heart failure trials, and as an associate editor for Circulation and European Journal of Heart Failure. Finally, Professor Lam is seen regularly on television as the resident doctor of the health program Body and Soul in Singapore. Welcome to Heart Success, Dr. Lam.
Thank you. It's my pleasure and privilege to be on the show.
Do you mind if I call you Caroline for the interview?
Please do. And thank you. And first, congratulations for the success of Heart Success.
Thank you so much.
I know what it's like to do a podcast, and in the midst of all that you do, congratulations.
No, absolutely. And bringing us to listening to podcasts, I've been listening to Circulation on the Run right from the first episode. And although when I started, I was a general cardiology fellow, I think, when I started. And I love the new style that you've taken over that is more conversational and incredible episodes.
Well, I really couldn't thank you enough. And really, that new style is all thanks to Greg Huntley, my pal, my partner, and I really am grateful to Circulation that we can do this. I've been very by how it's been received, not just in the U.S., but also here in Asia, in Japan and China. And it's really, really, I consider it one of my greatest privileges to do it. So thank you.
Oh, it's fun. It's fun, especially when you guys question each other and, pull each other's leg. Those questions are really hard. So.
Okay, I need to tell Greg to do that more. Okay.
So I was wondering maybe you could share with us what you do right now, your role currently, because you do practice in Singapore.
Yes.
And also maybe you could tell us, because you play multiple hats in the same day. You're a physician, you're an educator, you're a researcher, you're a journal editor, and a podcaster. So how do you manage to do it all?
Oh, I might ask you the same question, but okay, here's my humble opinion. It's always a balancing act. I mean, at the end of the day, I think I define myself as a clinical trialist. I was trained in heart failure. I did that at the Mayo Clinic, and so grateful for those days that really set me in the right step. I also spent a lot of time at the Brigham with people who have really inspired me to today, like Scott Solomon, and then later on John McMurray. And so, they've been my examples in the clinical trial world. I've begun to really, really enjoy that, having done a lot of sort of real world regional registry work. And then the editorship came as a complementary way of understanding how we need to communicate our results better, and to be part of that team has really been one of the greatest blessings of my entire career. So Joe Hill as editor-in-chief is absolutely awesome. I say that with a capital A, and I say it with all my heart. He and James Dilemmas have actually been like awesome bosses to work for. So I don't even consider it work. I actually love being able to communicate results, because I really believe that while we may know what's the right thing to do, unless it's implemented and communicated, it doesn't really reach the patient. And so what I do as well is have a little TV show in Singapore. It's called Body and Soul. And there I try to reach out to the public and empower them with information. And don't laugh, but I actually talk about everything from like presbyopia to warts on your skin to heart attack and stuff like that, which I find very fulfilling. Of course, though, you can imagine me before every show sort of reading up my medical textbooks and wanting to be really responsible for the information. So I think what I can say is I'm really, really doing what I love. And it's all interconnected somehow, even if it may not seem so. And that's how you keep it going. Balancing act.
Absolutely. Thank you for that. So, in some of the previous episodes, we've discussed guideline-directed medical therapy in heart failure. We've been talking about how maybe we're moving from triple therapy today, which is ARNIs, ACEARB, beta blockers, and mineralocorticoid receptor antagonists, to quadruple therapy, where SGLT2 inhibitors have a role. But a lot of the research that has been done in outpatients. I thought today we could take some time to delve into some of the inpatient management of these patients and how we maybe approach to starting some of these medications in the hospital, because we know that starting in the hospital actually is a big step to knowing that they will be on this medicine in outpatient follow-up and will stay on this medicine long term. So I was wondering maybe you could share a little bit into inpatient management of your heart failure patients, your approach to managing heart failure.
Wow. Okay. That's a great question. So first, the inpatient management, I couldn't agree with you more. It's a really great opportunity to target the patients at highest risk. And I mean, we've seen this time and time again. In the most recent, I suppose, would be the ARNI results, both in HephREF, in the pioneer and transition studies, as well as in HFpEF. If you've noticed the most recent analysis from Paragon that was presented at the latest American Heart Association meeting really showed that the absolute risk reduction achieved with ARNI appeared to be greatest in those closest to the hospitalization period, sort of saying, should we be really, really focusing on the inpatients as a vulnerable group? It's a great opportunity because in my country, going to my own practice, we manage inpatients' heart failure as a group, as a heart failure service, and therefore a heart failure program. And so that's what heart failure really needs, a multidisciplinary approach. You've got nurses who are very good at helping us remember to up-titrate medicines and where we may have forgotten this or that. I mean, you are absolutely right that heart failure management has become, some people say complex, and that may be the case, but it's also so much better now that we have many, many choices. So for me, we always start with the basics of neurohormonal blockade. So this is once patients are, of course, more hemodynamically stable. We don't put a hypotensive patients on, ACEARBs or ARNI, for example. So not a cardiogenic shock patient, in other words, and we've already diuresed them adequately. That alone is an art. And then, it's always institute the triple therapy that we can institute. And we may not be able to get them to the highest tolerable dose, but we at least get them to a heart failure program where we have faith that they will be up-titrated in future. And importantly, monitored for side effects, right? Because hyperkalemia, renal dysfunction remains an issue that we should be thinking about. Now, of course, now with dapagliflozin entering the scene, I have not built it into our pathways per se yet, but I do really believe in both the editorial that was written for DAPA HF, as well as that beautiful paper that including Eugene Braunwald shared in writing that this is now the new foundation and pillar. It is totally amazing how that's going to be put into actual guidelines, which then translate into our clinical practice pathways, I think still remains to be seen. So on a personal level, I do consider it. I mean, it becomes a no-brainer once it's a diabetic patient. Yeah. In a non-diabetic patient, I know that the results are robust. I do have a conversation with the patient to say this is new, the results are very robust. And I do also warn them to understand why we are giving it. Yeah. I don't want them to go home and kind of tell their GP, I think my doctor made a mistake. I have no diabetes. They gave me a diabetic med. You know what I mean? And, and then all the things to prevent the side effects. So one thing I do look out for in administering any SGLT2 inhibitors is to make sure that I warn the patient about side effects, and that would be urinary or genital infections, right? But beyond that, it's this euglycemic diabetic ketoacidosis. So that's something that we as cardiologists are not used to dealing with or picking up, but we really have to look out for these things now.
Yeah, thanks. And, if you listen to the other SGLT2 inhibitor episodes, we discussed this in detail, nausea, vomiting, signs and symptoms to watch out for. So excellent point.
So those are my thoughts about the inpatient management.
And the other thing that you just mentioned is so important, that if they're really hypotensive, really not the time to start some of these meds, really focus on other things, diurese them as best you can. One of the other questions that constantly comes up, and I think we're doing a better job today, is using beta blockers in these patients. So among patients who are already coming in on beta blockers, what is your approach to the dose? Do you leave it the same? Do you cut down the dose? Discontinue at all in certain cases? And secondly, if it's a de novo heart failure patient, when do you initiate beta blocker in that patient's management in hospital?
Good question. So if the patient comes in on a stable dose of beta blockers, and it's really just fluid overloaded, but really hemodynamically rock stable, I try to persist with the beta blockers on board. If I really think I need to, I can half the dose or put it to the minimal dose. I really, really try not to take it off. Now, very different case if it's cardiogenic shock, or that's the clinical acumen, right? Where this patient looks like it's going to turn for the worst. I do take those off. Those would be the times where I'm also putting them in a high dependency unit, ready to start inotropes if they need. So it's that kind of patient. You definitely take off the beta blockers.
No, and totally. And in de novo patients, if you're seeing someone who's diagnosed with a new cardiomyopathy,
yes,
heart failure.
Yes. The second half of your question. So for those, I don't start the beta blocker right away. I actually diurese them, and then I tend to start the ACE first. But before I up-titrate the ACE, leaving no blood pressure space, I do add the beta blocker. Whatever it is, the patient's not going to go home unless they're on a beta blocker already, Yeah.
I agree. That's the same approach I have, is get them on all the meds and then up titrate later, because I think that's where the inertia sets in once they're on a medication and they're not on something. So, the other question that comes up inpatient as well is getting them on the right beta blocker, because do you commonly switch them? For beta blockers, for example, we have best evidence for carvedilol, metoprolol, and bisoprolol. But there are still patients out there, a few of them, on atenolol, on some of these other beta blockers that we don't have a lot of data, cardiovascular data for, propranolol, for example. What is your approach to this?
I do switch them, and then I take it as a learning opportunity to sort of, let the fellows I work with explain why I switch them. But I feel that's my value add, right, as a heart failure trained cardiologist who knows the guidelines. And so, yes, I do switch them. It's a very good point.
And ARNIs, are you switching maybe patients on ACE and ARB to angiotensin receptor neprilysin inhibitors in the hospital?
Very often, yes. Yes, we do that. And frankly, I mean, with the new Pioneer and Transition, well, maybe it's not even new anymore, data, where they even had ACE or ARB naive patients in it, I find it very convincing. I mean, I will never forget, there was a session when Milton Packer spoke at one of the large conferences, and sort of polled the audience, who are all cardiologists, and said, if you had HFrEF, would you start yourself on an ACE and fail an ACE or whatever first and then switch an ARNI, or would you start straight away with an ARNI? And, and of course that is considering that cost is not an issue, everything else is not an issue, And that was even before we had Pioneer and Transition data. So I think he's got a point.
And now we actually have strong data suggesting it's safe to do so. And
yes,
most of the cases I'll look for a reason not to do it. And
yes,
always is one of those reasons, yes.
Yes, I do think, though, where there may be a little bit of question marks remaining is the combination of ARNI and SGLT2 inhibitor or dapagliflozin in particular started in the in-hospital setting. DAPA-HF did include a subgroup that were on ARNI, and there was no heterogeneity of benefit with dapagliflozin in those who were or were not on ARNI to begin with. So that is reassuring that the two can be used together. However, I think, it's still a small subgroup, and I think here, real world experience, and if we go into an earlier population, those things would tell us how that combination may work in sort of the more acute heart failure situation.
No, absolutely. The use of ARNI in DAPA heart failure was only 11% of all patients. So relatively.
Yeah.
So, the other thing I wanted to maybe focus on also is the non-cardiac medications. When we see these patients, commonly they stay on medications that have minimal evidence to be on, but they're not cardiac, and some of them may actually be harmful.
Several previous papers have addressed this class of medications that you could address as heart failure exacerbating medications. In fact, the data suggests that up to 40% of the patients being admitted for decompensated heart failure may have one such medication, at least one such medication on their list, and 37% of these patients continue to have this medication on their list even at the time of discharge, so an opportunity missed. Let me describe some of the specific drug classes that may be regarded as heart failure exacerbating medications. This comes from a scientific statement that was published in Circulation in 2018. One of the first drug classes that becomes relevant are anti-inflammatory medications, be it steroids or NSAIDs, which are known to exacerbate fluid overload and heart failure. Another class of drugs are the cardiovascular drugs, such as antiarrhythmics, which one could be pro-arrhythmic in certain cases, especially in the presence of LV dysfunction or prior myocardial infarction. Second, a lot of them have significant negative inotropy or conduction issues, so you want to watch out for these as well on the medication list. Calcium channel blockers, especially the non-dihydropyridine calcium channel blockers such as diltiazem and verapamil, they have potent negative inotropy, and I can't tell you the number of cases I've seen them exacerbate heart failure or push patients with heart failure into cardiogenic shock. Additionally, dihydropyridine calcium channel blockers such as short-acting nifedipine are also relatively contraindicated in patients with HFrEF. You want to be careful with certain diabetic medications, such as thiazolidinediones that have been known to exacerbate heart failure. Some data for concern among using GLP-1 agonists among patients with advanced heart failure disease, really untested territory. Another class of drugs that you want to be careful with is phosphodiesterase inhibitors such as cilostazol, and in certain cases maybe even PDE5 inhibitors such as sildenafil. We will briefly talk about sildenafil in our upcoming episode where we discuss the ACC trials, but this class of drugs doesn't really have a clear established role in patients with heart failure currently. Some neurologic and psychiatric medications, really amphetamines, a lot of people out there, younger folks who you may see on Adderall now have tachycardia, reduced EF. You want to consider whether or not it is the right time to switch them to maybe a non-amphetamine medication for their psychiatric issues or neurological issues. Other psychiatric or neurological medications are the ergot alkaloids, which we know, ergotamine, dihydroergotamine, very, very minimally used. I don't see them as much anymore. The tricyclic antidepressants, because they do have a negative inotropic effect and a proarrhythmic effect. Carbamazepine, clozapine, and the other medications also, which are categorized sort of in the miscellaneous group, which are beta-2 agonists. Do these patients really need to be on these beta-2 agonists? Do they need to be on trimethoprim, sulfamethoxazole, because it could worsen hyperkalemia when taken with ACE inhibitors and ARBs? Some of these sodium-containing preparations, especially the fleet enemas, you want to remember the fleet enemas. QTC prolonging medications, which are some of the antibiotics like erythromycin, some of the antipsychotics like haloperidol. And of course, in current times, we worry about the combination of hydroxychloroquine and azithromycin in causing significant QT prolongation and cardiac arrhythmias, especially among susceptible populations. So really, when you're looking at the drug list, you do want to think about all these medications and the risk-benefit in individual cases of continuing these medications. So Dr. Lam, what is your approach to these medications? Do you typically defer these to the specialties and just reach out to them, let them know, or do you bring it up with your patients right away?
That's an excellent point. And obviously I'm preaching to the choir here with what you've just mentioned. You're absolutely right. So for those drugs that are contraindicated, I most certainly stop them. And of course, at the back of my mind, I know someone else put them there for a reason, but then you always explain it to the patient why you're taking it off. And I do take it as an opportunity to do that and reconcile meds. I really, really think that's a central role of a heart failure physician as well. But, talking about meds for other non-cardiac or comorbidities, there are a few that come to mind. I mean, I always remind myself, have I vaccinated this patient? I don't think it should be underestimated that they need their yearly flu vaccination. I also check iron deficiency. Now, whether you think that's a cardiac med or not, that's a different argument, because it does affect mitochondrial energetics and it could do so in the myocardium. But I do think it's one of those comorbidities that really, when you address it, I've seen my patients really thank me. They just feel so much better when they have iron deficiency. And note that I'm saying iron deficiency and not iron deficiency anemia. So you can really have a lot of iron deficiency with a reduced transferrin saturation with a rock normal hemoglobin.
Yes.
And those patients still really benefit from intravenous iron. That's from the trials like FAIR HF and so on, but it's also from experience. I've seen that. One thing I really struggle with when it comes to comorbidities is renal impairment. Don't know what to do yet, and I think we really, really need a medication that can be used down to low GFRs. By the way, now that I've mentioned that, we will be really looking forward to the Victoria results. So Victoria, remind you, is vericiguat in patients who had a worsening heart failure. So, pretty close to their heart failure events, be it hospitalization or urgent visits. And I think those late-breaking results are going to be announced soon. We might have another medication.
And was that a HFrEF group, or was it a HFpEF group, the Victoria?
It's HephREF. So Victoria was HFrEF, but there is a sister trial called Vitality that's HFpEF. So we'll see.
At the time of this interview, we didn't have results from Victoria, subsequently presented at the American College of Cardiology meeting. So in our next episode, when we do ACC 2020 trials, we talk about Victoria at length and describe the trial in detail.
To your point on iron, I think that's a great point. We've been doing that more and more, looking for iron deficiency while they're in the hospital, because it's a great opportunity to put them on IV iron. And recently on Twitter, literally in the last week, Stephen Pettit, who's a UK-based cardiologist, put out a poll to say, what's your practice and what are you doing with IV iron in the hospital? And it came up how most centers were either going with just 1 gram IV iron, either ferric carboxymaltose, just because people didn't want to get into the calculations of it. But what people were doing is using the Gonzoni formula, which was used in the trials, to actually total how much iron deficiency there is, because, again, like you said, there may be some data that giving them full iron may be beneficial for their functional status, NYHA class improved functional status. So I'm glad you brought it up, because it's an
wow. And
management.
Yeah, and have you experienced that patients literally feel better,
Absolutely,
within days? Yeah,
and
it's quite amazing.
Such a great point, because like you said, outpatient getting IV iron can be difficult because it's an intravenous thing. So I think in hospital is a great opportunity to be able to start using this, and I do it all the time in practice, assisted by a pharmacist, so it makes life a little bit easier at times. But change in practice for sure.
Yeah, and let's remember though, these would be like a stabilized pre-discharge type patient, like not in the acute throngs of, the acute pulmonary edema, definitely not, and also not in the presence of sepsis. So you have to make sure it's not a septic patient. Yeah.
Great points. No, thank you. I thought maybe we could move in the second part of our discussion to heart failure and preserved ejection fraction. And
favorite topic.
Why it's so important to talk about HFpEF today, and the challenges experienced with even something as simple as diagnosing HFpEF in practice.
Yeah. Okay. Well, why is it so important? Well, you have to admit that half the heart failure population, or in fact, the dominant portion of heart failure patients that we see today have to be important, right? So we know that those above ejection fraction 40 do constitute the majority of patients, even today in elderly societies like Japan. And I think even today in the US, it's at least 50%, if not more. We've been really struggling with this, from people believing, does it exist, to people saying, is it just a bag of comorbidities and nothing more, so you'll never be able to cure it because it's just comorbidities, to sort of inching closer. And I do think that the Paragon trial of Arnie in HFpEF was really, really landmark in the sense that it brought us much closer to understanding the disease. So a couple of things about Paragon, first, it looked at recurrent heart failure hospitalizations or total heart failure hospitalization burden, rather than time to first heart failure hospitalization, which is what all prior trials did. And it looked like that made a big difference. And it's also reminding us that these patients, although we thought differently previously, they do die less frequently than patients with HFrEF, but they are hospitalized just as often. So being hospitalized is really an important outcome, and we should design trials to look at that. So that's one thing. Another thing we learned, I think, from Paragon is not just formal heart failure hospitalization, but urgent heart failure visits are increasingly important in our modern practice. I think that the overall Paragon results were, just missed its primary endpoint with a P of 0.059. Well, guess what? If we had included the urgent heart failure visits, which there were only 15 urgent heart failure visit difference between the treatment arm and the control arm, that would have led to a p-value under 0.05. So, so kind of learned that lesson. The other thing we learned is that there may be heterogeneity, and the one most talked about is by ejection fraction. So one of the pre-specified subgroups to look at was to look at the effect of sacubitril valsartan above and below the median ejection fraction in Paragon, which was 57%. And lo and behold, it was actually a significant interaction, and significant even after adjusting for multiple other covariates. So a multivariable, adjusted, independent, significant interaction that was pre-specified and in a large subgroup. If we say median EF, it's obviously half the patient population. And so now we're wondering, because ARNI appeared to work in those with ejection fraction less than 57%, but not so much in those above 57%. I really think it's causing us to question, when we look at the paradigm data in totality, is this mid-range ejection fraction? And if so, should these mid-range ejection fraction, about 40 to 55% EF, should they more appropriately be thought of as mildly reduced, following the MR term, mildly reduced ejection fraction, and treated as such? I think the community is sort of shifting towards that, along with other post-hoc analysis we've seen from the CHARM program, from TopCat and so on. But it's a lot of learning. I think we're moving forward slowly but surely, but we're not quite there yet. Yeah, I'm really looking forward to the dapagliflozin in HFpEF results. So that would be the DELIVER trial. And as we mentioned earlier, there's vericiguat in HFpEF with Vitality. All these are ongoing and very exciting.
We're trying newer drug classes because this is a disease that is very heterogeneous across different ages and across different body sizes even. May be different in the disease itself, So something that comes up even with cardiologists, I've noticed, is, all HFpEF patients have diastolic dysfunction on echocardiogram. And I think, unfortunately, that's how it was always started as. And you showed in the PROMISE HFpEF trial that there's so much more to these patients going on. So I was wondering maybe if you could allude to some of the pathophysiology that goes behind HFpEF.
Yeah, most people ask me to shut up when I try to talk about it because they start to see stars, and then after a while I also feel embarrassed because we talk about the pathophysiology that we think exists. We believe in the evidence, but then the trial fails, right? So but thank you for giving me an opportunity, because I really, really do think microvascular inflammation is a really key part of this syndrome. I use the word syndrome very carefully because it is. HFpEF is a syndrome. And I think a large sort of the garden variety part of this syndrome are really just comorbidity-driven microvascular inflammation. And so we were the first in a multinational prospective fashion to show that by actually imaging the coronary microvasculature for reduced coronary flow reserve. And that was the PROMISE HFpEF trial. And we really showed that the great majority of patients with HFpEF, prospectively well-characterized HFpEF, have this reduced coronary flow reserve, or in other words, evidence of microvascular dysfunction. And remember, this is even in the absence of known or revascularized macrovascular coronary artery disease. So just because a patient doesn't have, big coronary artery disease in the epicardial vessels doesn't mean that microvasculature is not affected. The other thing that, of course, always intrigues me is that microvascular angina has always been known to be a woman's disease. So, and then now we also know that HFpEF tends to be elderly women. So yeah, I think there's something there. In this respect, we have failed in many attempts to sort of douse the microvascular inflammation. We thought we would do it by adding nitrates. That failed. We're trying to do that by enhancing cyclic GMP, so vericiguat with soluble guanylate cyclase. That's good. We don't really know if ARNI work by enhancing natriuretic peptides and enhancing cyclic GMP. We think so, but how much of it's due to that, And then finally, there is an ongoing phase 2 trial now known as the satellite trial, and it's a myeloperoxidase inhibitor. that's really directly trying to address inflammation in the vessels with a myeloperoxidase inhibitor. So we'll see, I think time will tell.
Talking about the inpatient management of HFpEF, we don't really have a lot of evidence beyond blood pressure control and diuretics. Are you using mineralocorticoid receptor antagonists or even Entresto in certain patients right now?
What a great question. So mineralocorticoid antagonists, I like to say I find any excuse to use them. So I find a reason to give them so that I don't say that I give MRAs because of a positive TopCat trial. TopCat was neutral overall. People talk about the regional variation, but then the regional heterogeneity interaction test was not significant. So what I do say, though, is the patient, if he's hypertensive, he or she, I'll use mineralocorticoids. If I need it for potassium sparing effect, instead of giving loop diuretics and potassium, I give loop diuretics and a mineralocorticoid receptor antagonist. So I think that somehow it really does work very well in these scenarios. I'm also very glad to see it's part of a 2B recommendation now by ACCHA, and they say those with raised natriuretic peptide. So in those cases too, sure, why not? There's always reasons to use mineralocorticoid receptor antagonists. Now, Arnie, I'm still sort of, coming from all the announcements of the Paragon results, and I frankly think that those with a mildly reduced ejection fraction, I'm quite convinced with the data. So, I'm especially considering totality with Paradigm. So henceforth, I will consider in my patients with an ejection fraction less than 50, 55 maybe, I'll see. And maybe after a good discussion, shared decision-making with the patient, consider ARNIs.
The other thing about diagnosis has been, and some of this data comes from the Mayo Clinic, where patients with ambulatory symptoms of shortness of breath sometimes have resting normal hemodynamics. So they've used exercise data, fluid challenge data, and then we also have, I think some of this again coming from the Mayo Clinic, on using the diastolic echocardiogram stress testing in these patients. So is this something you're using in practice for some of these patients that have symptoms with exertion but resting hemodynamics may be really borderline normal?
Yeah. So I'm very torn in what I'm about to answer. So first, I think super highly of the Mayo Clinic data that they can do invasive hemodynamic exercise testing, like not just invasive hemodynamic, but invasive hemodynamic exercise testing in their patients is awesome. If we could all do that, we would solve the problem of identifying HFpEF. The problem is we can't. And in Singapore, I really frankly don't have opportunity to do that. And my patients don't want anything invasive done to them. So I just want to put that aside for a while. The other thing is, of course, then the non-invasive diastolic stress testing. We do that. We do have that. But I have to say that although that's in the new Heart Failure Association guidelines for guidelines, what do they call it? Consensus? Not guidelines, consensus for HFpEF diagnosis. It's also not easy. I think the thresholds for diagnosis and so on are admittedly not foolproof and so on. So I actually don't use it in every patient, for example. I frankly don't struggle with the diagnosis of HFpEF because I just make the diagnosis of heart failure.
Yes.
As long as I'm sure it's fluid overload, it's just those classic symptoms and signs. And then I find a preserved ejection fraction and it's usually just staring me in the face that there's diastolic dysfunction, a raised E to E pride, and the gut feel of being with the patient, that it's this fluid overload that's giving their symptoms. Yeah. And that's where I go from there, So I only use it in cases where I'm really, really not sure.
And that's these resources are not available in the community, especially. So
yeah.
So the last question in HFpEF really is devices that have come up. We have the intra-atrial shunt devices. We definitely have the CardioMEMS device that is being used previously in RCT fashion. what do you think is the role for using devices in HFpEF treatment, since medication so far have really struggled to make an impact?
Yeah, I've been humbled by the effect devices have had. So really, really hats off to the PIs who've led this. Bill Abraham, Sanjeev Shah. Oh my goodness, they're just favorite colleagues of mine. I have to admit that I was agnostic when I first understood the concept of the interatrial shunt. I was afraid to death of Eisenmenger syndrome and paradoxical embolism and things like that. But I have to say that the trials so far have been very reassuring and promising. And in fact, the pivotal trial is ongoing now. So I really, really, would say watch this space. It's hot. It's really, really hot. And I suppose it makes sense, right? If it's a safe thing, it does make sense. You have a pressure pop-off valve almost for the left atrium. As long as it's safe and in a controlled size and doesn't get clogged up and so on, it would probably work, as it's been shown. So about the cardiomems, though, I take it as a learning lesson that we doctors really, really are poor with assessing filling pressures. And that we probably don't diurese our patients enough because, just the insertion of a monitor keeps the patient out of hospital. No, it's not the monitor. It's what the doctors gave in response, right? So, and what were those? More diuretics and more vasodilators. So it's just a lesson to me to not forget that HFpEF is first Hef. So treat the Hef part. So treat the fluid overload and the congestion. And we tend to forget that in the midst of everything.
No, thank you. That was great. I'm glad we went into a lot of the management questions to both HFrEF and HFpEF and sharing your insight into how you translate that into clinical practice. Any last comments, plugs, pointers, anything else you'd like to tell our audience?
No, only to say it's been such a pleasure to be on this show and to just, everyone please appreciate what you do. It is not easy to do a podcast and to do it so well. So thank you so much. It was a true pleasure.
Thank you so much, Carolyn.
If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestions for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links to all the podcast providers where you can listen to this episode. You can find us on our Facebook page at Heart Success Team, or you can always reach me on Twitter at CardioBro.